All right, welcome to this explainer on the authoritative 2026 AHIMA and ACDIS guidelines for clinical documentation integrity. If you're a medical coder, a CDI specialist, or a compliance director, you already know that the query process is basically the bridge between clinical care and accurate coding. And yeah, it is a massive target for auditors. So today, we're breaking down these newly updated standards to make sure your clarification process is compliant, effective, and completely bulletproof. So, here's our game plan for today. We'll be looking at query timing, the non-leading language rule, how to resolve conflicting documentation, conducting verbal queries, and finally, securing the provider response. Okay, starting right off with Section 1, Query Timing Across Settings, understanding when to clarify documentation. So, the query lifecycle really follows three distinct phases. First up, you've got concurrent queries. These are issued actively during the patient's day for real-time clarification. Next, we have retrospective queries, which happen post-discharge, but, right before that final claim gets submitted to the payer. And lastly, post-bill queries. These happen after final billing, typically when you're dealing with internal or external audits. Now, keep in mind, in outpatient settings, doing a concurrent review is honestly pretty impractical just because those encounters are so incredibly short. And because of that crazy time crunch for our ambulatory and outpatient teams, it's super important to note that HCC risk adjustment queries, yeah, they are bound by the exact same strict standards as inpatient queries. You can absolutely look at prior encounters to grab some clinical context, like, say, checking a previous GFR to stage chronic kidney disease. But that past documentation literally cannot be the only basis for a new query. You need a current clinical trigger. So no blind mining of past records, okay? Moving right along to Section 2, the non-leading language rule. Framing clinical facts neutrally. You know what's wild? A simple query title can actually be flagged as non-compliant if it points the provider in a direction before they even look at the clinical indicators. If your subject line is query for acute hypoxic respiratory failure, well, you've already led the witness. A compliant title has to be totally neutral, something like CDI provider query respiratory status. The provider has to get to the diagnosis using their own independent clinical brainpower, not our hints. As CDI pros, our whole mandate is to state the facts neutrally. That means completely zeroing out any talk about reimbursement impact, denial mitigation, or quality measures. You cannot just nudge a doctor and say, hey, documenting this really helps our severity of illness metrics. That is absolutely prohibited. Plus, every single clinical indicator you use has to come straight from the record, pinpointing its exact location with absolutely none of your own subjective spin on it. Let's actually look at how this plays out in real life. If a patient's hemoglobin is 10 grams per deciliter, you just report the exact lab value. You directly quote, hemoglobin is reported at 10 grams per deciliter. What you never, ever do is cross that line into diagnosing by writing anemia as your indicator. Interpreting that lab value is the physician's job. We're just here to serve up the objective data. Right, let's jump into Section 3, resolving conflicting provider documentation, navigating clinical friction. So, we've all been here. It's a classic dilemma. The hospitalist writes one thing in the progress note, let's say acute renal failure, but then the consulting nephrologist puts chronic kidney disease in their consult note. Two completely different stories. So, who do you actually query to fix this discrepancy? The definitive answer? The attending provider, always. They hold the ultimate responsibility for the patient's entire diagnosis and care plan. Now, sure, a specialist's diagnosis is usually fine to accept without a query if it's just adding specificity, but the literal second there's a conflict, the attending physician has to be the one to step in and reconcile the record. Also, queries have to go directly to the face-to-face treating clinician, meaning you cannot just shoot a query over to a physician advisor or a medical director who never actually treated the patient just to snag a quick signature. The diagnosis has to come from the treating provider. Oh, and a quick nuance, telehealth providers, they are totally eligible to receive queries as long as they were clinically responsible for the encounter. Face-to-face in this context really means clinical involvement, not just being physically in the room. All right, Section 4, conducting compliant verbal queries, real-time professional etiquette. Listen, a casual chat by the coffee machine is not a query. The moment you ask a doctor for documentation specificity about a specific patient encounter, boom, you are bound by strict verbal query protocols. The 2026 guidelines are crystal clear on this. Verbal queries have to be tracked and recorded exactly the same way you track a written one. You basically have to memorialize the entire conversation to prove it was totally objective. It's a 5-step process. First, get the date, time, and who was there. Second, List the exact clinical indicators you brought up. Third, document the non-leading question you asked, along with the options you gave them. And finally, step 5, write down the provider's exact verbal response.
But here's the kicker. If the physician verbally agrees to a diagnosis while you're talking, but then forgets to actually write it into the permanent health record or add an addendum, you literally cannot assign the code. The CDI specialist's personal notes on the chat mean absolutely nothing for coding. The provider has to authenticate it themselves in the record. And that brings us to our final pillar, Section 5, Securing the Provider Response, Cementing the Legal Health Record. Whether you're using a multiple choice setup for clinical validation or just a simple yes or no format for a present-on-admission query, you always have to give the clinician an other free text option. They need room to exercise their own independent clinical judgment. You also got to give them clear options to explicitly agree, disagree, or completely rule out a condition. Now, for POA and just no queries, including the unable to determine option is mandatory, and this is a big one. It represents true clinical uncertainty right at the time of the encounter, meaning they just don't have the evidence to make a call yet. And please remember, this is totally different from an uncertain diagnosis, like possible or unable to rule out. Unable to determine literally means they cannot give you an answer right now. Ultimately, once the provider authenticates it, that query and their response are locked in. They are cemented as a permanent, legally binding part of the health record. It captures exactly what their clinical judgment was in that specific moment, which gives your coding team exactly what they need to confidently assign the right codes.
So as we wrap up this explainer, I really want you to think about your own facility's practices. Seriously, with AI and automated EHR nudges everywhere now, are you 100% sure your technology isn't accidentally leading the witness? Because every single alert, every single template has to follow these exact same rules. If an auditor pulled a random sample of your automated queries tomorrow, would your revenue actually survive the scrutiny? Please like, share, subscribe to Decode Healthcare with Harshal.